So you can see here on the left of the urine, it's really dark. It takes a little while to get dark because it needs to be essentially oxidized, so it needs exposure to air or base, so alkali, for example. On the right is a normal urine. And the disorder of having the brown accumulation in connective tissue and the destruction of it is called ochronosis. That's the accumulation of the HGA, or homogentic acid. This discoloration can occur in any cartilage that's visible to us. So, for example, the cartilage of the ear, in the little curvature that you see in the ear, that can turn black and actually can appear more blue sometimes. Or in the eye, we have the muscles of our eye moving us left and right and up and down and obliquely, etc. The insertion of those muscles has some cartilaginous material, and that can turn dark too. So you can have a spot that's really to one side of the pupil that's black, and that is a sign of ochronosis as well. There's a lot of variability in this disorder and in its presentations. But again, the main problem here is with the joints, the connective tissue of the joints, so ligaments and things like that. And in particular, the first thing that generally happens in that regard is at the spine. And what happens to the spine is that the intervertebral discs, so the space between the vertebrae, becomes destroyed. And it shows some calcification as well. So here are some pictures of that osteoarthritis. On the left is a normal spine. The second one from the left shows where the arrow is, that the intervertebral disc space has been reduced. It's been shortened. And there's a little bit of calcification there. In the one to the right of that, this has occurred in all of their intervertebral discs, and it's worse. And finally, in the one on the right, there's fusion in the middle two vertebrae, so they're actually fused together. And that's not good. So this causes pain and decreased mobility. Those would also be black if you ever operated on them, as some orthopedists do. But mainly the joints that orthopedists operate on are going to be the other large joints, namely the shoulders and the hips and the knees. There are also cardiac complications, and these largely relate to homogentic acid and its products forming on the valves of the heart, especially the aortic valve. And this occurs later in life. The first symptoms of alkaptonuria generally occur in the 30s. And that first symptom is going to be involvement of the spine. And then later on, the shoulders, knees, and hips are involved, and the cardiac involvement occurs around age 40 and on, usually in the 50s or so. There are also kidney stones and prostate stones. And the pain of all of these different involvements of ochronosis is what impairs the quality of life of individuals with this disorder. So what patients generally undergo is a particular journey to diagnosis, and then to dealing with the diagnosis, and now with the availability of Harlequin to treatment. Remember, screening does not occur at birth. So you're not going to get a metabolic screen back from the nursery that says so-and-so has alkaptonuria. But you might see those stained diapers and make a diagnosis then, especially if the pediatrician or family medicine doctor recognizes that the dark stain of the urines is a sign of alkaptonuria. Otherwise, the diagnosis is missed. Family history can often contribute. If you have a brother or a sister who might have had this and was diagnosed, then that person should be checked as well, especially if there are any symptoms involved. And I just mentioned what the symptoms would be, largely orthopedic symptomatology, or sometimes cardiac as well. And then there's a referral to a geneticist or a metabolic clinic. And if they do the right tests, they'll make the diagnosis and have long-term management. Again, adults in their 30s and 40s are the ones who will be more inclined to get a diagnosis. And the diagnosis can be made by the dermatologists because of the appearance of the cartilage that's seen through the skin, or by the rheumatologists or orthopedists. The ophthalmologist can see that black spot in the white of the eye, internists, and then sometimes there's a kidney stone that shows up and turns out to be black when it's passed. So if you suspect alkaptonuria, then you come to the long-term management by internists, by family practitioners, and primary care doctors. The challenges are that it's so rare that we don't see it very much. Actually, in medical school, we all learn about it in first-year biochemistry because of what I told you about the history of alkaptonuria being so important in inborn errors of metabolism and in our field of biochemical genetics. There's slow progression, and that makes it difficult to diagnose as well. And it's often mistaken for other disorders of arthritis and the skin. However, the diagnosis can be made by the patient history. We've just gone through some of the findings, by the physical examination as well, and by laboratory tests, and especially a test of urine organic acids, because homogentic acid is an organic acid, and it's often vastly increased. So the homogentic acid would normally be about 100 or 200 milligrams per day excreted in the urine, in a 24-hour urine. And in alkaptonuria, it's 5 to 15 grams. So it's like 50, 100 times elevated. You can't mistake that, and it will be detected on urine organic acids. Then imaging studies will show you some of the abnormalities in the bones and joints, as I demonstrated with the intervertebral disc narrowing. Clinical evaluation should involve a history of when the patient first had any symptoms, the duration of the symptoms, and the severity, which can be highly variable. Men tend to be diagnosed and have symptomatology about 10 years earlier than women. There are significant pain characteristics, and in order to control the pain, patients will take analgesics that generally work, but that's part of the history to determine how dependent they are on those analgesics. Also, there can be essentially occupational exposure. So, for example, you might not want to have alkaptonuria if you were a linebacker in the NFL. In other words, the more you use your joints and bones and hurt them, the more it's going to hurt you, and the more there's going to be progression of the orthopedic findings in this disorder. For clinical evaluation, of course, the physical exam is important. The joint examination is especially critical, looking for swelling, tenderness, deformities, and range of motion, which will be impaired. You can, again, look for the pigmentation or the ochronosis in the skin. And I mentioned some of the areas where you can look. Again, the brown spots in the whites of the eye is important. The ear exam is not important for inside the ear as much as it is for the outside of the ear, where the cartilage is very close to the skin, and that can be blue or brown or black. And a cardiac exam is very important for the valve disease. There can occasionally be neurological involvement as well. Lab tests, again, check organic acids for the homogentic acid. Be good to get blood counts to essentially rule out other things, because infection, inflammation, anemia, and other conditions could be occurring. And the SED rate and the C-reactive protein can be checked, but they're not generally elevated. Again, because rheumatologists would see some of these findings and see some of the patients with these findings, they might consider an arthritic condition or rheumatological disorder and therefore get inflammatory markers. They're generally not elevated in alkaptonuria. Kidney function to be assessed, and liver function as well. And then genetic testing for the gene, the homogentisate dioxygenase gene, can make the diagnosis or confirm the diagnosis. But again, the mainstay of the diagnosis is urine organic acids showing this vast elevation in homogentic acid. And finally, imaging studies, x-rays, looking at the joints, looking for calcification, as I pointed out, in the intervertebral discs and other abnormalities in the spine and joints. MRI can give you an indication of some of the soft tissues, and that would include the tendons and ligaments and cartilage that's involved by the ochronosis. In addition, the echocardiograms are very helpful to determine if there's valve disease in the heart, especially the aortic valve.
Important safety information. Indications. Harlequin is indicated for the reduction of urine homogentisic acid, HGA, in adult patients with alkaptonuria, AKU. Important safety information. Do not prescribe Harlequin to patients allergic to nitisinone or any other contained ingredients. Warnings and precautions. Ocular symptoms and hyperkeratotic plaques due to elevated plasma tyrosine level. Ocular signs and symptoms including keratitis, corneal opacities, corneal irritation, corneal ulcers, conjunctivitis, eye pain, and photophobia have been reported in patients. Perform slit lamp examination prior to treatment and regularly thereafter. Re-examine patients if symptoms develop or tyrosine levels are greater than 500 micromoles per liter. Assess plasma tyrosine levels in patients with an abrupt change in neurological status. Perform a clinical laboratory assessment, including plasma tyrosine levels, in patients with an abrupt change in neurological status. Leukopenia and severe thrombocytopenia. In clinical trials, patients with hereditary tyrosinemia type 1, HT1, treated with another oral formulation of nitisinone and dietary restriction, developed reversible leukopenia, thrombocytopenia, or both. No patients developed infections or bleeding as a result of the episodes of leukopenia and thrombocytopenia. Monitor platelet and white blood cell counts during Harlequin therapy. Adverse reactions. The most common adverse reactions, greater than or equal to 1%, reported in patients with AKU taking nitisinone in clinical trials are elevated tyrosine levels, thrombocytopenia, and keratitis. Drug interactions. Nitisinone is a moderate CYP2C9 inhibitor and a weak CYP2E1 inducer. Potential clinical impact of Harlequin administration with CYP2C9 substrates. Reduce the dosage of the co-administered drugs metabolized by CYP2C9 by half. Additional dosage adjustments may be needed. Nitisinone is an inhibitor of OAT1/OAT3. Potential clinical impact of administration with OAT1/OAT3 substrates. Patients should be monitored for potential adverse reactions. Use in specific populations. Pregnancy. Limited available data with nitisinone use in pregnant women are not sufficient to determine a drug-associated risk of adverse developmental outcomes. The background risk of major birth defects and miscarriage for the indicated population is unknown. All pregnancies have a background risk of birth defect, loss, or other adverse outcomes. Lactation. The developmental and health benefits of breastfeeding should be considered against the mother's clinical need for Harlequin, along with potential adverse effects on the breastfed infant from Harlequin or from the underlying maternal condition. Pediatric use. The safety and effectiveness of Harlequin have not been established in pediatric patients with AKU. Geriatric use. Insufficient data from clinical studies of Harlequin to determine if patients greater than or equal to 65 years of age respond differently. Elderly patients should be cautious reflecting any decreased hepatic, renal, or cardiac function, and of concomitant disease or other drug therapy. For more detailed information, please refer to the full prescribing information at harlequin.com/PI. To report suspected adverse reactions, contact Cycle Pharmaceuticals at 1-855-831-5413 or the FDA at 1-800-FDA-1088 or www.fda.gov/medwatch.